What we are looking is the uncinate process of the pancreas, which is right here. You are not seeing the bile duct very well because there is so much of inflammation. And I'm going to enlarge the screen. You can see there's a small fluid collection inside the uncinate, and you gradually pull through. And then when you're coming to the neck of the pancreas, you're going to see a large necrotic collection. So this is all pancreas, and there you see the pancreatic duct in between with a hyperochoic margin. So you gradually pull back, and then I'm going to fall into the stomach, and you see this necrotic fluid collection. Another thing that is important is to see if there is any pancreas distal to it. You can see all this is a collection. It's all probably liquefied, and then at the inferior margin you got solid debris, and then you pull back here. You see this is important. This is a disconnected pancreatic duct. So this is towards the tail of the pancreas. You've got some sort of a normal pancreas, and then if you trace that, it will go into this fluid collection. So this patient has got a disconnected pancreatic duct syndrome in conjunction with a walled-off necrosis. So this is important because when these patients tend to have a much more severe course than a patient without a disconnected duct, which means they will require more necrosectomy and so forth. When the stent is removed in 4 weeks' time, it is important to replace it with a plastic stent. Otherwise, over a period of 1 to 2 years, the patient will have a recurrence. So the second next thing to do is to make sure there is no intervening vasculature in the path of the needle. Again, I'm going to unlock the device, and I'm going to move it down to make sure it's going in a direction I want. I think we are now fixed to cautery. So I position it very well because I need some space for this to go in. And I'm directly into the collection. So step 1 is done. The step 2 is just removing the safety valve, and then you unlock it. You hold it like a syringe, and then you deploy the flange, and usually you can see it very nicely on EUS guidance. So this is a 20 millimeter device, and then you pull back tiny bit, and you can wash your lens to make sure that you're seeing the black mark. I'm going to pull the scope back. You can still see there's a white mark. If you see white, it's too deep inside. So now I'm going to retract it, and there I see the black mark with an interface. Lock it again, and then you go to the last step, which is to unlock and deploy the last part of the flange. This is it. You push it out.
And you see that the flange is deployed into the scope, and
yes.
then
I'm going to just gradually withdraw it. This is pretty much the deployment process is complete. So we're going to aspirate very, very aggressively. And one of the things this is important to realize in Axios placement is this is only the first step over several sequential things that must be done to make this patient feel better. So I'm going to suck as much as I can, and you can see there's a lot of necrotic material. Once you get the fluid as much as possible, I will pass an ERCP or a standard cannula into the fluid collection, and then I will lavage it until most of the necrotic material passes out.
Excellent demonstration, perfect, and the patient should really benefit. So thank you so much.